Excellent. Yeah, thanks. This was one of the Friday satellite symposia. It was one of the earlier sessions, but I have to be totally honest and surprised it was very well attended. My co-moderators or co-panelists included Dr. Diaz-Campello from Spain, as well as Dr. Aditi Shastri from New York. And we were essentially tasked with giving a lay of the land of what is going on for the patient that has lower risk MDS, an admittedly heterogeneous population of patients, and really how we think through, in this case, case-based fashion, what are we trying to address? In most of these patients, it's going to be symptomatic or transfusion-dependent anemia. These two things, not complete overlap. And what sort of strategies are available to us? Is this just proceeding with red cell transfusions, or do we offer more anemia-directed therapy like ESAs? These days, EMAs, with the chief product being Luspatercept, now has 2 approvals, and we expect its use to really increase over time, including amongst our community providers. But what about those patients that actually are failed by ESA? It's just, in many, if not most cases, inevitably going to happen to every patient. In which case we actually look to, of course, clinical trial being the right answer, but what other avenues, novel mechanisms of action, including things that might be approved quite soon and we're enthusiastic to really use and really impart to our patients. Based on pretty reasonable data to show it's very effective with, even though this term is often hackneyed or trite, a manageable safety profile. The key one that we haven't named yet is Imetelstat or Imetelstat. And beyond that, what's on the horizon? What's in the future with regards to not only therapies, but risk stratification and other support structures that might have to be emphasized, especially as more of these patients are treated in the community.